Mike, from an operational standpoint, because I know you have instituted the injection, because it's a 1 minute injection,
right.
4 weeks apart. How are you following these patients? Because we know that the survival benefit is for 6 cycles. How are you following these patients in terms of their markers, their PSAs, their alk phos, their albumins? We know you have to get CBCs before you infuse. What are you doing for these patients specifically? Are you following their lab at 3 months, 6 months? How are you guys doing?
So we get a series of labs after their first infusion, again, CBC, just to make sure everything is going well per the protocol. And then we get these patients in an every 2-month rhythm of, basically every 1 to 2 months they're coming in, they're getting their infusions, and they're alternating, getting their labs in between. And they're getting their testosterone and their PSA and their vitamin D, their calcium levels. We're not doing those that often, the testosterone and calcium levels and vitamin D levels, but we have routine intervals where we get these labs. And once they're getting this drug, once they have bone mets, they need to be followed closely. You can't let these guys come back every 6 months, every 4 months. I think you need to follow these patients every couple months. Even if you're coming in with one of your extenders, which is how we work it. We have 2 extenders that see advanced prostate cancer patients, and we have a nurse navigator. So we have a whole team of people that will see these patients in between our visits, and I think that's important. And we adopted that model from our medical oncology friends here on our panel. Urologists typically we're pretty slow on the uptake for these kind of things.
Well, good point. I mean, I think culturally most urologists are in the mindset of seeing patients every 3 months, 3 to 6 months, and to change the culture to see patients monthly and making that transition from the 3-month visit to the 1-month visit is something that is a teachable moment. We really don't do that, but it's now that urologists are in this space, they need to remember that. Most of my partners were catatonic at the suggestion, so
I think that when you think logistically, at least from the medical oncology perspective, as to how should you manage those patients getting Radium-223, I think the most important thing is not who owns the patient, nuclear medicine, radiation oncology, or what have you, is to make sure that you have one person as a quarterback of that patient. Because at the end of the day, right, if you look, the median number of cycles given Simca was 6 cycles, but in practice, in real life, in the post-chemotherapy setting, we are one of the largest, have one of the largest experiences with Radium-223 in the country. I can tell you that the median number of cycles given in the post-chemotherapy space, which is probably the first bubble after registration, was actually 3 to 4 cycles, around 4 cycles or so, right? And patients do have side effects, and specifically, that myelosuppression, you see it, right? And by label, you may not need to actually have a hemoglobin, all the time, 10.5 or so, but you can see sometimes patients drifting down. Right. And the biggest question is, how do you support those patients, right? So I think for me personally, in my group, we see those patients on a monthly basis, right? They either see the nurse practitioner, the physician assistant, or myself. We'll check their labs, and then they go straight to nuclear medicine, they get the infusion, and then we'll see them. For those patients who are really adamant to see their PSA, we oftentimes have to do PSAs, just to be honest with you, just to follow and to have a cohesive approach. But the reality of it is, for us, we often, as we discussed that with you before, Raul, we do scans only when we actually believe we need to actually make changes in treatment decisions, right? In the Simca, there was no imaging follow-up, right? So that's why we actually think about skeletal symptomatic events, not SREs defined by imaging. So none of us know, in fact, how to follow those patients imaging-wise. None of us know the impact of Radium-223 with regards to fluoride PET, colon PET, technetium-99, and so forth. So the reality of it is most of us will complete therapy and then restage the patient. Some of us believe that maybe getting a scan in the middle, especially a CT, would be useful for us not to miss those patients who are about to develop visceral metastases. But most of us will just wait until they complete the therapy and get them a scan.
See, I would say that if you got a scan in the middle, it's not necessarily to stop therapy.
Correct.
Because we know the survival benefit is with 6 cycles. It would be, if somebody's progressing, should you add another agent?
Correct.
So,
Right.
I think it's important to remember that, again, for Radium-223, just as we've discussed, there's a survival benefit. It's an alpha emitter, so it has less myelosuppression, although there is still a risk. There is a reduction, there is a benefit in terms of reduction of skeletal-related events, symptomatic skeletal events. It does reduce the amount of analgesics that the patient requires. in terms of opioids or non-opiates. It needs to be administered, however, either by radiation oncologists or nuclear medicine. We have a lot of interest by a lot of groups, large independent practices in the United States, urologists who want to incorporate this in terms of how to do this within their own center. So, Mike, again, I know you guys have recently adopted this. Operationally, take us through that, how difficult it is, those types of things.
Sure. So first, it's not difficult, and I think this ties into, you have to have the infrastructure to support these services, whether you're dispensing the oral oncolytics or whether you're giving Xofigo, and I think you have to do it for the right reasons, which is really the patient, to really follow the patient, take control of the patient. Once you've made that decision, then you have to have a conversation. We are a COPN state, so we do not have radiation oncology within our practice. So we talked to our independent radiation group that we've been working with for years, and we approached them and asked them if they would want to consider doing infusions at our site, because we were already doing a majority of other things, including all of our research trials on site. They agreed to it, and from that process it was licensure with the state of Virginia, going through radiation safety plan, which they helped create. We hired a physics company to go through the logistics of what to do in our office, and it was about a 45 to 60-day process to get up and running. They come in, and we actually have a multidisciplinary clinic, if you will, where they come in and they see the patients, evaluate the patients, and then we set the patient up on another subsequent appointment for them to be infused by the radiation oncologist and the therapist who we've hired. So fairly straightforward.
Great. And again, I think everybody should understand there are some regulatory issues, and some of it's also going to be state by state.
Absolutely.
But again, it can be delivered either by radiation oncologist or nuclear medicine.